Hello, everyone, and welcome to our module on multiple sclerosis. Multiple sclerosis is a central nervous system disorder, so this means that it affects the brain and spinal cord, but not peripheral nerves. It's an autoimmune condition, which we'll talk about in a minute, and the main way that it affects nerve function is that it leads to demyelination. It usually follows a relapsing, remitting course. We'll talk about this in a minute. So patients have flares, which then resolve, and they go into remission for a period of time and then can have another flare. And so it's been said that multiple sclerosis is a disease of time and space. This means that it involves time, it comes and goes in terms of symptoms, and it involves space, as we'll see in a minute. It can involve lots of different locations in the central nervous system. Let's talk about the risk factors for multiple sclerosis. So the classic demographic to develop this condition is a female in the age range of 20 to 40, so much younger than the age range where you would see strokes and things like that. Some other risk factors are listed on this slide. Family history is important. Smoking and obesity raise the risk of this condition. Patients who've had a prior Epstein-Barr virus infection, meaning they've had mononucleosis, are at increased risk. It's long been thought that a virus may trigger this infection, although no definite virus has ever been identified. But nevertheless, a prior infection with Epstein-Barr does raise the risk of multiple sclerosis. And then finally, this is an autoimmune condition, so patients with other autoimmune diseases like type 1 diabetes, inflammatory bowel disease, rheumatoid arthritis, lupus, etc., they're more likely to develop multiple sclerosis. Okay, and then multiple sclerosis has a couple of strange risk factors, so let's talk about those now. The first two are low sunlight exposure and low vitamin D level. For reasons that are poorly understood, it's thought that a high vitamin D level is protective. So if you have either of these two things here, that's associated with a low vitamin D level, and that's associated with higher risk of multiple sclerosis. And then also for reasons that are poorly understood, the geographic location where you spend your childhood influences your risk of multiple sclerosis. The further you are from the equator, the more likely you are to get MS. So patients that live in so-called temperate climates like the United States are at higher risk than patients that live along the equator like in South and Central America. Once again, people think this may be because a virus or some environmental pathogen triggers the disease, but no one's ever discovered what that is. Okay, let's talk about the pathophysiology of multiple sclerosis. So as I mentioned at the beginning of this video, this is a condition of autoimmune demyelination. So for reasons that are poorly understood, something triggers chronic inflammation around nerves, and this leads to damage of axons. There can be gliosis, which means inflammation in the central nervous system. This can lead to astrocytic scarring, basically scar tissue forming in the spinal cord or brain. And then also you can lose oligodendrocytes. And this is high yield to remember for step one. They're going to want you to understand that patients with this condition lack myelin, and oligodendrocytes are the cells that produce myelin in the central nervous system. T cells are also important. It's thought that they react to myelin antigens, and that's part of what triggers the autoimmune response. And then B cells, which become plasma cells and produce antibodies, are also important. As we'll see in a minute, patients with multiple sclerosis have a finding in the cerebrospinal fluid called oligoclonal bands, and this is due to the presence of antibodies. Okay, so what are the consequences of demyelination in multiple sclerosis? Well, this is a central nervous system disorder, so it's going to affect the brain and spinal neurons. And some of the common neurons that are affected are those of the optic nerve and the medial longitudinal fasciculus, which is a brainstem structure. We'll talk more about this in a minute, but problems related to these highly myelinated neurons in the central nervous system often lead to the initial presentation of multiple sclerosis. You can also see myelinated spinal cord tracts affected, and this can lead to weakness, and it will be spastic upper motor neuron weakness because these are central nervous system neurons that are affected. Another sort of buzzword to know about multiple sclerosis is that it's associated with reduced saltatory conduction. So saltatory conduction is the type of conduction that occurs in myelinated nerves where signals jump from one node to another past the myelin. And I talk about this in the videos on nervous system structures. So saltatory conduction is the kind of conduction you get in myelinated nerves. This is in contrast to continuous conduction, which is what you get in unmyelinated nerves. And so then because you have problems with saltatory conduction and conduction along myelinated nerves, this leads to slower transmission of signals. It also leads to more energy required to conduct signals, and that leads to fatigue. So a common complaint of patients with multiple sclerosis, which we'll talk about later, is fatigue. Also, when these axons don't work, they can misfire or send distorted signals. They can even have ectopic firing where they spontaneously discharge. And so this leads to symptoms that we'll also talk about later in MS, like paresthesias, which is numbness and tingling, and also pain. The most common clinical course of multiple sclerosis is relapsing remitting. This occurs in up to 90% of patients. This refers to episodes where symptoms acutely worsen And then between episodes, there's either a partial or a complete recovery. And so that's what's shown at the top of the slide right here. The patient has a flare. There can be a period of remission, then another flare. Sometimes they go all the way back to complete recovery between episodes. Sometimes they only have a partial recovery. Less commonly, patients can have these other patterns shown down here. One's called secondary progressive. That's what's shown right here. The other's called primary progressive. That's what's shown here. The most important one to understand for your exams is this common relapsing remitting course. So the way that multiple sclerosis initially presents is as a so-called clinically isolated syndrome. This refers to a first episode of multiple sclerosis neurologic symptoms in someone who has no history of prior MS symptoms. Now, multiple sclerosis is famous for being able to cause any neurologic symptom, but there are a couple of classic syndromes, which I've listed here, and we'll go through in the next couple of slides, which are the way this condition often presents. All of these relate to demyelination of highly myelinated structures in the central nervous system. So optic neuritis is a condition that can occur on its own, but it's a classic first presentation of multiple sclerosis. So in optic neuritis, there's inflammation of the optic nerve, and this leads to demyelination of the optic nerve. This leads to acute monocular vision loss, so it will classically present with loss of vision in one eye, but not in the other eye. Because there's inflammation of the optic nerve, this will lead to eye pain, especially when the eyeball is moved, because that tugs on the optic nerve. And then another classic complaint is color vision changes. So for example, patients will say red colors appear washed out, or that overall colors appear dull in their visual fields. Also, when you have optic neuritis and you shine light into the affected eye, the pupil will not constrict normally. This is called an afferent pupillary defect, and I discuss this in detail in videos in the ophthalmology section. This condition can be treated with intravenous corticosteroids, and as I said, it's often a first presentation of multiple sclerosis. Another super classic initial presentation of multiple sclerosis is internuclear ophthalmoplegia. This is a horizontal gaze disorder that I talk about in detail in the ophthalmology section. I'll just briefly review it here. So patients with MS who develop this condition will complain of diplopia or double vision, especially when looking to one side. The reason they have this problem is because the medial longitudinal fasciculus in the brainstem has become abnormal for multiple sclerosis. This is a highly myelinated structure in the brainstem that's vulnerable to multiple sclerosis lesions. What will happen when the patient tries to look to one side is what's shown in this little image I've created here on the slide. So one eyeball will move to the side just like it should. The other eyeball will move to the midline, but then it will get stuck at the midline. The adducting eye, the eye that's trying to move towards the nose, will get stuck with no movement past midline. That's what happens when you have an MLF lesion. The other eye, the abducting eye, will move laterally, but then it will realize that it's out of sync, and so it will start to bounce back and forth, and that's called nystagmus, or the presence of saccades. Patients with MS can also present initially with brainstem and cerebellar syndromes related to demyelination of nerves in the brainstem and cerebellum. So this can lead to clinical features like ataxia, where the patient complains of loss of balance, vertigo, nystagmus, facial numbness. Another somewhat common complaint is dysarthria. This means difficulty moving the muscles to speak. So patients will have what's called scanning speech, where their words are broken up and separated by pauses, and the words are spoken with varying force. And then the fourth sort of common initial presentation of MS is called partial transverse myelitis. This basically means a spinal cord lesion due to MS. The word transverse is in the name because it affects one level of the cord, and the word partial is in the name because it affects only the left or right side of the spinal cord. So this is going to lead to motor and sensory symptoms below the level of the lesion. The motor symptoms will be ipsilateral. The sensory symptoms can be ipsilateral or contralateral depending upon which senses you're talking about. So you will have ipsilateral vibration and proprioception loss, contralateral pain and temperature loss, and this is similar to the Brown-Séquard syndrome, which I talk about in videos on spinal cord disorders. You can also see bowel and bladder dysfunction, and really all these things are just evidence of spinal cord involvement of multiple sclerosis. I've listed some other important clinical features of MS on this slide. So I mentioned this earlier, but fatigue is extremely common among patients affected by MS, and that's because it takes additional energy to send nerve signals because you've lost myelination. Bladder dysfunction is also a major issue in patients who have multiple sclerosis. When you lose the normal innervation to the bladder from the brain and spinal cord, the detrusor muscle in the bladder becomes overactive, a condition called overactive bladder. This leads to urge incontinence, which is a form of urine loss that I talk about in videos in the reproductive section. Basically, patients will complain of urgency, frequency, and incontinence. In the video on headaches, I talk in detail about trigeminal neuralgia, but you should know that this condition is 20 times more common in patients who have multiple sclerosis compared to the general population. And sometimes in multiple sclerosis, it's even bilateral instead of unilateral the way it usually is. Trigeminal neuralgia refers to the sudden onset of facial pain, usually in the distribution of V2 and V3 of the trigeminal nerve, which is this area shown in blue. It presents with sharp, shock-like symptoms that come and go, and once again, I talk about it in more detail in the video on headaches. A couple of other clinical features you could see in an MS patient are described in this slide. The first one is called Lermite sign. This refers to an electric shock-like sensation that goes down the neck and spine into the limbs. This often comes on when patients flex their neck. It's basically just a sign of a pain syndrome that's associated with MS. And then Udolph sign refers to the fact that symptoms of MS often worsen with heat. The hotter the body gets, the less nerve conductivity there can be in nerves affected by MS. So patients who are in the midst of an MS flare often want to avoid getting overheated. And then Charcot's neurologic triad is a collection of 3 clinical features that you can see when the cerebellum or brainstem are affected by MS. So this refers to scanning speech, which we talked about earlier, intention tremor, which I talk about in other videos, and also nystagmus of the eyes. The diagnosis of MS is usually made through identification of clinical features like all the symptoms we've been talking about in the last few slides, plus MRI findings. So the best first test in a patient suspected of having MS is usually going to be an MRI of the brain and spinal cord. One of the things it can show is simply oval-shaped plaques that represent regions of demyelination. These can be anywhere in the brain and spinal cord. In many cases, some of the plaques will appear new and some will appear old. This represents the relapsing, remitting nature of the disease. Another classic finding is the presence of Dawson's fingers on MRI. This refers to demyelination near the ventricles of the brain, so-called periventricular demyelination. If you look at this image on the right, this is a nice example of Dawson's fingers. So this is one of the ventricles here, and you've got these white lesions sticking out from the ventricles. They kind of look like fingers. Those are Dawson's fingers. Now, there are cases where the symptoms are vague or the MRI is non-diagnostic, and there are 2 other tests that are sometimes done. One is a lumbar puncture to sample the CSF, and another is called a visual evoked potential. So let's talk about those 2 tests now. So if you do a lumbar puncture, there are some classic CSF findings that you can see in patients who have MS. The major one is the presence of oligoclonal bands. This refers to a class of antibodies that create a band on gel electrophoresis. This is seen in about 85% of patients who have MS. And basically what these oligoclonal bands represent is an increased amount of IgG in the cerebrospinal fluid. So if you look at this image on the slide, this is a normal gel electrophoresis. And this region out here is very faint, indicating no bands, meaning no antibodies. Over here is a patient who has multiple sclerosis. It's much darker in this region. This is positive for the presence of oligoclonal bands. That's what you see in MS. So a so-called positive CSF in a patient who has multiple sclerosis usually means the presence of oligoclonal bands, that's this finding shown right here, and an increased IgG level in the CSF fluid. Visual evoked potentials are another test you can do that's supportive of the diagnosis of MS. This is a test that evaluates optic nerve conduction. Basically, you place electrodes on the back of the head, similar to the way that would be done to record an EEG, and then a visual stimulus is shown to the patient, and you measure the time it takes for that stimulus to generate a reading in the visual cortex in the back of the head. You get a readout that looks something like what's shown here. It has this peak called the P100 peak, and the time it takes for that peak to be generated is delayed in multiple sclerosis. This indicates optic nerve demyelination. So in a person who has vague symptoms of optic neuritis or vague symptoms of MS, when the MRI is non-diagnostic, this can support the diagnosis of multiple sclerosis. Okay, I'll finish this video by talking about the treatment of multiple sclerosis. So when patients experience an acute exacerbation of neurologic symptoms, the usual treatment is IV corticosteroids, usually methylprednisolone. These drugs have been shown to speed recovery, although they don't alter the long-term prognosis. To change the long-term prognosis, you have to use other drugs. The long-term treatments of multiple sclerosis are designed to limit exacerbations and disease progression. These drugs are also called disease-modifying therapies. One of them is interferon beta. This is a drug that basically inhibits T-cell function to limit autoimmune attack. It's given as a subcutaneous injection, like what's shown here, and it has few major side effects. Another option is glatiramer. So this drug is a mix of polymers that are derived from 4 amino acids. So that makes its structure similar to myelin basic protein, a protein found on myelin that T cells attack. So what happens when you give this drug is the T cells bind the drug instead of binding to myelin basic protein found on neurons. And then what this does is it triggers T cells to divide and form more Th2 cells and regulatory T cells and less Th1 cells, which are pro-inflammatory. Basically, this drug changes the makeup of the type of T cells that are responding to myelin basic protein so that the T cells are less dangerous to the body. This drug is also administered subcutaneously and it has few major side effects. Another long-term disease-modifying therapy for MS is natalizumab. So this is an antibody drug. All drugs that end in AB are antibody drugs. And the antibodies of natalizumab are directed against the alpha-4 subunit of integrin molecules. So why is that important? Well, these molecules are expressed on lymphocytes, and they allow lymphocytes to adhere to the vascular endothelium and get into the brain. So by binding to integrin molecules, natalizumab makes it harder for white blood cells to get into the brain and cause MS. This drug is administered as an infusion. Patients have to go to an infusion center once a week or once a month to receive the therapy. And the biggest risk of this drug, and it's super high yield to know this for board exams at all levels, is that it's associated with progressive multifocal leukoencephalopathy, or PML. This is a central nervous system disorder related to reactivation of a latent JC virus infection, and I talk about it in detail in other videos. The risk of this condition is higher in patients who have anti-JC virus antibodies indicating exposure to the JC virus. And so for this reason, before this drug is given, patients are tested for antibodies to the JC virus. They're also tested for other things like tuberculosis exposure, Hep B exposure, and Hep C exposure. And the idea here is that this drug causes immunosuppression, and it can cause any of these latent type infections to flare. The biggest risk is for the JC virus to be latent in the body and flare, causing PML. So remember what I said before, that incontinence and urinary problems are a big issue in multiple sclerosis. This condition is called neurogenic bladder, and there are a couple of special treatments used for this particular problem. One is the drug oxybutynin, which I talk about in other videos. It's an anticholinergic drug. It's a muscarinic antagonist, and it basically blocks contractions of the detrusor muscle in the bladder and reduces those involuntary muscle contractions that cause patients to spill urine. Mirabegron is a beta-3 adrenergic agonist, so we don't talk about beta-3 receptors very much. We mostly talk about beta-1 and beta-2, but there are some beta-3 receptors found on the detrusor muscle in the bladder, and when you activate those with this drug, it relaxes the detrusor muscle so it doesn't contract and push urine out involuntarily. And then, believe it or not, botulinum toxin injections are sometimes used to treat neurogenic bladder and multiple sclerosis. Botulinum toxin inhibits acetylcholine release from parasympathetic nerves, and this is going to relax the bladder muscle. It's injected directly into the muscle using a cystoscope, meaning a camera that's inserted into the bladder so you can visualize the walls of the bladder. And after these injections, that relaxes the bladder muscle and reduces overactivity. And then some other treatments for bladder problems related to MS are simply bladder training. This basically means educating the patient about using a urination schedule to keep their bladder empty so they can't involuntarily lose urine. Pelvic floor exercises can strengthen the muscles of the pelvic floor to help the patient hold in urine. And then intermittent catheterizations are sometimes done. The patient inserts a catheter to keep the bladder empty. Spasticity is also a major problem in multiple sclerosis. Remember that this is a central nervous system disorder. So that leads to upper motor neuron type weakness, which involves spastic paralysis, and muscles can be in a chronic state of contraction. This is called spasticity. Some of the treatments for the spasticity of MS are shown in this slide. One is a drug called baclofen. Baclofen is a GABA B receptor agonist. GABA B receptors are found on lower motor neurons in the spinal cord. And when they are activated by a drug like baclofen, the neurons become hyperpolarized. This basically leads to less transmission through lower motor neurons, which are supplying muscles. As a result, you get less activation of muscles and less spasticity. You can also use benzodiazepines to treat spasticity. Benzodiazepines work on GABA A receptors, which are very different from GABA B receptors. GABA A receptors are found throughout the nervous system, and when they're activated, they generally have an inhibitory effect, and that can improve spasticity. And so benzodiazepines are agonists to these receptors. And then just like in treating bladder problems of MS, botulinum toxin also has a role in treating the spasticity of MS. As I mentioned on the last slide, injections of botulinum toxin prevent the release of acetylcholine, and this leads to less stimulation of muscle fibers. And this can lead to a temporary 3 to 6 months relaxed state of a particular muscle group that has problems with spasticity. And then I mentioned this earlier, but chronic pain related to nerve dysfunction is a major issue in multiple sclerosis. There are a couple of classes of drugs that are used to treat this problem. The first are the tricyclic antidepressants, which I talk about in the psychiatry section. These are drugs like amitriptyline and nortriptyline. They are serotonin and norepinephrine reuptake inhibitors, and they basically modulate pain perception and can improve the symptoms of pain in MS. The other very commonly used drug class to treat neuropathic pain from multiple sclerosis are the gabapentinoids. These are drugs like gabapentin and pregabalin, which I talk about in detail in the anticonvulsant videos. They stabilize nerve membranes and decrease hyperexcitability, and that leads to less pain transmission. And that concludes our module on multiple sclerosis.